My topic is Pulse in Acute Ischemic Stroke Care. I will be discussing some technical aspects with regard to the hyperacute ischemic stroke management in next 15 minutes during my presentation. Hyperacute ischemic stroke management is a very dynamic process. You need to act very, very fast. Due to a stroke, a person can become permanently disabled. If a stroke is identified with development of symptoms, it can be treated. Thus, the risk of brain tissue injury can be minimized and the disability can be minimized. Hyperacute ischemic stroke management is time sensitive and critical to improving outcomes for patients. The goal in this hyperacute phase is to quickly restore blood flow to the ischemic brain tissue and minimize the damage. Acute stroke causes an irreversibly damaged infarct core and salvageable surrounding tissue. Penumbra is the reversibly injured brain tissue around the infarcted core. The earliest rescue of penumbra is key for treating ischemic stroke. In simple words, we have a blocked artery. The area supplied by that blocked artery is dying. We want to stop ischemic penumbra becoming an infarcted area. To do that, we need to reopen the blocked blood vessel and re-establish blood flow to the ischemic area as soon as possible. There are two options available to do this. One is thrombolysis, and we can try to recanalize the block vessels in ischemic stroke with thrombolysis or thrombectomy. Thrombolysis can be done using either intravenous alteplase or recombinant tissue plasminogen activator or intravenous tenecteplase. As the first step, a quick history taking and a focused physical and neurological examination should be done. The most important thing is the clinical diagnosis of stroke. For that, we need to assess the rapidity of the development of the symptoms. We know stroke typically presents with sudden onset neurological symptoms. It can be sudden onset face, arm, leg weakness, it can be sudden onset speech disturbance, or it could be sudden onset gait imbalance. The next important thing is the time of onset of neurological symptoms. Knowing the last known well time is critical for determining the options, treatment options, particularly deciding on thrombolysis and thrombectomy eligibility. The next step is the assessment of the severity of the stroke. Worldwide, the tool used to assess the severity of stroke is National Institute of Health Stroke Scale. NIHSS quantifies the stroke severity, and it is very important for decision making. Normally, NIHSS of more than 5 and less than 25 patients are considered for thrombolysis. Patients who are stable should be immediately sent to the radiology department and imaged with a non-contrast CT. Non-contrast CT plays a vital, a crucial, and a first-line role in the management of acute ischemic stroke. The advantages of this is that it's widely available and very fast and very sensitive to exclude acute bleeding. The main purpose of performing a non-contrast CT is to rule out hemorrhage. In addition to that, non-contrast CT can assess early signs of ischemia, and sometimes it will be helpful to identify large vessel occlusions, but we need to arrange CT angiogram if we want to confirm large vessel occlusions. The major important step in hyperacute ischemic stroke management is to identify the patients who are within the window period. We know, as I mentioned earlier, last known well time is very important. We know the window period for thrombolysis traditionally it is 4.5 hours from the onset of symptoms, and thrombectomy it is 6 hours. But in recent years, the window period for acute ischemic stroke management has been extended significantly beyond the traditional 4.5 hour and 6 hour limit. In selected patients, CT perfusion scan can justify thrombolysis beyond 4.5 hours, often up to 9 hours or more, by demonstrating small infarct core, a large penumbra, and a mismatch between core and penumbra, which is called CT core perfusion mismatch. This is especially useful in wake-up strokes and delayed presentation with minor and improving symptoms. This technique allows for a tissue-based decision-making rather than a time-based decision. MRI can also be helpful to identify patients who may benefit from thrombolysis, especially with patients with unclear onset stroke, wake-up strokes, and when we want to consider extension of window period and also to exclude stroke mimics. TWI flare mismatch seen on MRI can identify patients with recent stroke onset. DWI positive, flare negative suggest onset within 4.5 hours. In this picture, the upper row gives two examples of visible acute ischemic lesions on DWI, diffusion weighted imaging, while no marked parenchymal hyperintensity detected on MRI flare images, indicating DWI flare mismatch. In the lower row, a clear hypersensitivity can be seen on flare images. In the area of acute DWI lesion, there is no DWI flare mismatch. So the patients in the upper row can be considered for thrombolysis, and the patients in the lower row are not suitable for thrombolysis. Also, MRI perfusion scan can be used in the decision making for the extension of window period. MRI, particularly DWI, has high sensitivity and specificity for acute ischemia. We know patients sometimes presented patients with seizures, migraines, and conversion disorders sometimes present with focal neurological deficits. And MRI DWI images can use to avoid unnecessary thrombolysis in stroke mimic like these conditions. Thrombectomy window period can be extended up to 24 hours in clearly selected patients with favorable perfusion imaging profiles. Selection is based on CT perfusion or MRI perfusion diffusion mismatch. When you are practically doing thrombolysis, one of the major challenge you will encounter is the management of blood pressure. Blood pressure should be kept below less than 185 by 110 before and during infusion of alteplase. And also the blood pressure should maintain below 180 by 105 within the next 24 hours after thrombolysis or thrombectomy. If the blood pressure is high, we can use intravenous drugs to control blood pressure, labetalol is the drug of choice. Labetalol can be given 10 milligrams or 20 milligrams over 2 minutes, which can be repeated in 10 minutes if needed. Sometimes we may have to use labetalol infusion, and the dose should be titrated to maintain systolic blood pressure between 150-160 and diastolic blood pressure between 90 and 100. Maximum dose of labetalol that can be given within 24 hours is 300 milligrams, and we should keep the heart rate more than 60 minutes. In patients not eligible for thrombolysis, blood pressure should be only reduced if it exceeds 220 and 120 or in the presence of hypertensive emergency. Blood pressure reduction should be gradual, not exceeding a reduction of more than 15% in the first 24 hours. Monitoring is very important. We should monitor the patients during the first 24 hours in an acute medical ward or a stroke unit. We should monitor GCS, pulse, BP every 15 minutes for 2 hours, then every 30 minutes for 6 hours, and then every hour for 18 minutes. And these are the charts recommended by the Ministry of Health to monitor patients after thrombolysis. Patients who received thrombolysis should be commenced on a single antiplatelet agent 24 hours after thrombolysis. We have to arrange a repeat non-contrast CT brain after 24 hours and make sure that there's no bleeding before starting antiplatelets. Symptomatic intracerebral hemorrhage is the most feared risk of thrombolysis. When we notice a sudden neurological deterioration during or shortly after thrombolysis, we have to consider hemorrhagic complication. We have to stop the infusion and repeat the non-contrast CT brain. More than 4-point deterioration in NIHSS stroke. NIHS stroke scale is defined as with the hemorrhage is defined as a symptomatic intracerebral hemorrhage. The one thing that I want to emphasize is that all hemorrhages after thrombolysis are not symptomatic. Not all hemorrhages cause adverse effect on thrombolysis outcome. Therefore, worldwide, a classification called ECAS classification is used to assess the post-thrombolysis hemorrhages, and they categorize hemorrhages into 4 categories, and HI1 and HI2, HI hemorrhagic infarctions, they say they are benign, and parenchymal hematomas, we categorize them as PH1 and PH2, and parenchymal hematomas are the pathological hemorrhages. So especially PH2 with dense hematoma involving more than 30% of infarcted area with significant mass effect, and this usually associated with worse outcomes. Immediate post-stroke care is important for the final outcome of the patient. We have to take necessary steps to prevent complications like aspiration pneumonia. We have to arrange rehabilitation and also look into secondary stroke prevention strategies. In conclusion, the key to successful hyperacute ischemic stroke management is prompt identification and treatment. Reperfusion therapies, including thrombolysis and mechanical thrombectomy are the cornerstones of treatment, but their timing, eligibility, and safety must be carefully assessed. Thank you.